Well, good morning, everybody. Welcome to Grand Rounds on this Wednesday. I'm speaking on the traditional and unceded lands of the Mi'kmaq people. We're all treaty people. And as people hopefully know, that our department is committed to trying to implement some of the truth and reconciliation recommendations, especially those around healthcare in terms of faculty development and recruitment and retention for First Nations healthcare workers. It's my pleasure to introduce our three speakers today. Renette Amaral-Lang was a nurse at the IWK, then a public health nurse, and then one of our bilingual nurse coordinators, and now is a school health partnership nurse with the Nova Scotia French School Board. Laura Callahan is a nurse practitioner with our mental health and addictions program. And also interesting, Laura helps run the camp. I'm trying to, what's the name of the camp again? Sorry, Laura, camp?
It's Camp SOAR, which stands
Camp
for
SOAR. Thank you. I couldn't read my own handwriting. That's terrible. But anyway, that looks after African refugee children and youth who want to have a camping experience. So that's, I didn't even know about that. So that's pretty cool. And Chantal Walsh is one of our health promotion specialists with the Child Health Safety Link here at the IWK. And they're going to be talking today about ethics and contemporary social issues, immigration, and integration, and tell us a little bit more about the N4 program, or the National Newcomer Navigation Network. And as a grandson of Syrian immigrants who came here over 100 years ago under pretty difficult circumstances, I'm really looking forward to hearing about this talk and how we welcome new Canadians. We're all new Canadians, except for our First Nations folks. So we all have stories of how our ancestors came here and struggled to settle and adjust, and how do we get better at it. So we're really looking forward to the talk. So I will hand it over. I'm not sure who's speaking first, but whoever would like to take the reins, it's all yours.
Thank you, Andrew. And that was a wonderful introduction. So again, just want to say before we begin, thank you for having us today to be able to share some of our experiences from this incredible program and this course, Ethics and Contemporary Social Issues, Immigration and Integration. Not sure why my slides were not going through here. I apologize. There we go. So we would also like to begin just by acknowledging that we are in Mi'kmaq, the unceded territory of the Mi'kmaq people. The IWK honors the culture and traditions of Indigenous people and populations and aspires to partner with them to improve health. As Andrew mentioned as well, we are all treaty people. Honoring our shared treaty relationship is one of many important steps we take toward reconciliation. Our three objectives for today are as follows. So to discuss the National Newcomer Navigation Network, or N4, which we will likely be referring to it as, because it is quite a full sentence there, to highlight examples of how the newcomer navigation lens has applied to our different departmental roles at the IWK, and to illustrate resources available through N4 that clinicians can use. There are three of us as part of this presentation today, so each will introduce themselves when we begin our separate sections, and also essentially tackle one of these main objectives moving forward. A few disclosures just before we begin. We felt it was important to indicate that those of us who have collaborated to develop this presentation are employees of IWK Health. This presentation is not influenced by any members of N4, nor are any of us presenters receiving any form of payment for participation today. There are no known conflicts of interest, and this presentation acknowledges that there is a need to continue to address social issues pertaining to immigration and integration among populations across Nova Scotia and beyond. So as Andrew shared, I am Chantal Walsh. I am a health promotion specialist with Child Safety Link here at the IWK, and we do fall and sit under the Healthy Populations and Provincial Initiatives Department. The timing of this opportunity for me personally to apply for this could not have come at a better time, just both personally and professionally. I applied for such in 2019. And so that was pre-pandemic, essentially, but In essence, the National Newcomer Navigation Network, or N4, is a pan-Canadian network for providers assisting newcomers in navigating Canadian healthcare and social service systems. It's a program that has partnered with St. Paul University in Ottawa to develop federally funded online educational opportunity. Its primary focus back in 2019 was on maternal and child health centers and organizations. So those include Children's Hospital of Eastern Ontario, Sick Kids Hospital, the Janeway Children's Health and Rehabilitation Center in Newfoundland, as well as IWK Health. And beyond that focus, they are now focusing on the educational sector. So looking at appealing to different educational sectors to also apply for and be partake in this particular program. The N4 online program is 1 year online. It's comprised of 8 full courses and 2 130-hour practicums. It is worth 30 credit hours in total. It is broken into 2 micro-certificates. So courses within the first micro-certificate between January and June focus on social justice, ethics, multiculturalism and immigration, interpersonal communication, as well as helping relationships and ethical considerations. And then once completed the first internship, the second micro-certificate would begin that July, focusing on courses in ethics and public service, local and community responses to conflict, and so on. The courses provided an opportunity for students with knowledge and guidance to better serve newcomer clients. And then, as I listed the courses that were available to us. And the practicums allowed us to apply the knowledge from these courses to solve real life challenges in our workplace. And we could conduct these practicums within our workplace by way of a mentor. And I know Renette will be speaking more specifically about the particulars within each. So it was a really great opportunity in that sense to be able to also fulfill our duties and roles in the work that we do. Approximately 10 to 12 hours of work per week for each course. There was a maximum of 30 students per cohort, and it was fairly flexible and accommodating to most schedules throughout. Just a quick run through of the application and relevance for me and my particular role within the IWK. I am working for a program that isn't typically focused clinically. So for me, it was challenging at times to apply some of those learnings in a non-clinical setting. However, it did force me to examine the parallels in my current work and the application of these learnings in possible situations and circumstances. So I could bring that lens forward. We focus on unintentional injury prevention. And so I was able to really apply that prevention lens that I would in my work every day to some of the work that I was learning and some of the education pieces I was learning in the course, supporting that when we see versus the if we see, so the primary prevention piece. It allowed me to connect with colleagues from across the country. And since completion of the course, I felt a call to apply and become part of the involvement with the IWK Equity, Diversity, Inclusion, and Reconciliation Steering Committee. So it has lent itself nicely to participation in some future development and future groups that are within the IWK. Now I'm going to pass it to my colleague, Laura Callahan, who will walk through a bit more of the why N4.
Thanks, Chantal. So just to give a brief introduction. So I'm a pediatric nurse practitioner that works with the mental health and addiction program and youth forensics. And more recently entered into a partnership with IWK and ISANS, which is the Immigrant Settlement Association of Nova Scotia. And there in that clinic, I see children and youth who present with mental health concerns. And that in particular came about as part of my involvement in the N4 internship program. So Chantal spoke a little bit about what N4 is all about. So I just wanted to take a few minutes today to speak to the why. So why is N4 helping newcomers navigate systems relevant to practice? So there are a number of answers to that question. Perhaps the most obvious of which is that N4 is relevant because it's in front of us. So there's an increasing trend globally where more and more people are facing circumstances that lead to forced migration. Nationally, the numbers have increased where in the past decades, maybe we saw 20 to 30,000 newcomers welcome to Canada annually. Now we see those numbers continue to rise. And the IRCC anticipates 401,000 newcomers to Canada in 2021 alone. So it's likely that you read a news article on the CBC about what is happening in different world geography with war, conflict, terrorism, poor health infrastructure, trauma. And then you see somebody in your clinic who has traveled from that situation, perhaps only a few weeks or months prior. The picture that you see on the slide was from an article less than a week ago, speaking of newcomers from Afghanistan as they settle into Halifax. As we know that the new influx of newcomers in the next few months will have very few primary healthcare supports. So newcomers will be more reliant on health systems and need navigation support now more than ever. As healthcare providers, we also need to have clinical knowledge to provide comprehensive and culturally relevant and responsive care. And I signed up for the N4 program hoping that I would be given the clinical pearls, the best practice guidelines, and the tools that I needed to know what to do to provide this evidence-based care. I've put together a list of some excellent resources, mostly websites, and they're brimming with great information. Likely you've already seen these, or you've accessed them, or you've referenced them in your own practice. But they really do provide helpful and tangible guidelines on things like, what is the best way to inquire about or ask about torture, demographics about specific countries and their cultural understandings of health, illness, and mental health. So really helpful and valuable information that I think is necessary to know as we provide care to newcomers. But N4 didn't give me any of the practical and pragmatic tools that I was hoping for. And so I was a bit frustrated sitting in courses about organizational ethics or social justice, gender, and disability, because it wasn't what I was hoping for. I wanted those tangible, practical pieces. And it took me a while to realize that I wasn't going to get any of those clinical guidelines. What N4 provided wasn't the what to do, but the how to think. And the shift in thinking, I believe, is not relevant, but essential if we are going to provide support to newcomers and systems. Canadians, I think, and healthcare professionals generally on the whole, I believe holds to the value that if we see injustice or if we see inequities in systems, that absolutely we would identify them and we would advocate for change. And for the most part, we do fight for change as much as possible in rather rigid systems. But what about the things that we don't see? That was a harder perspective shift for me to acknowledge. I'm a person with ego and pride, and my first response was, what do you mean? There are things that I don't see. I've been a nurse for 22 years. I've lived and practiced in various countries. I'm a pretty intuitive person. If I don't believe if there is a barrier or an equity right in front of me, that I wouldn't be able to see it. And yet you can't see what you can't see. As I wrestled with this perspective change, I thought of something that happened to me years ago. When my three oldest children were 7, 8, and 9, we were working and living in northern Kenya in an area of poor health infrastructure and incredible poverty. And the kids, as we neared the holidays, announced, like, Mom, we don't believe in Santa anymore. And I inquired as to the why. They noted, well, if Santa was who you said he was, then why hasn't he ever visited the Samburu children? So as I thought about the Santa revelation, I realized that my children saw the truth about Santa only because of their positioning in the world. If they had stayed in Canada with their grandparents who spoil them, or their presents in their pageants and their parties, they never would have been drawn to the same conclusion. And yet the truth about Santa was in front of them the whole time. They just couldn't see it. And this is a critical shift. I think on par with knowing how to treat people with clinical knowledge is the understanding of what we see and perhaps what we don't see. Because the things that we don't see are often the things that get in the way and impact newcomers as they access and enter into and receive care in our systems. Understanding this concept will lead us not just to attend to the patient in front of us, but ask about the patient who is absent, the patient who didn't make it into the clinic or is late or no-showed their appointment. Asking questions such as, why does our community demographic not always reflect the demographic of those who access our programs, services, and clinics? Our lack of vision, as Jonathan Swift would say, vision is the art of seeing that which is invisible, partnered with our lack of understanding the barriers newcomers face or the cultural elements to care, can lead us to make some pretty misguided assumptions. So I'll share a few assumptions that I've held recently. In the beginning of the summer, a young girl was referred to me in the ISIN's clinic. She was quite ill with social phobia to the point that she couldn't even leave her vehicle. I went with the mom to the car to greet the girl, and then the mom and I returned to the clinic. As I was walking back to the clinic, I kept thinking, why did the family wait so long to get access to help? Because the history noted that she had been declining for many months. As we were wrapping up the session, Mom, through the help of an interpreter, opened her wallet and brought out money and asked how much was the appointment going to cost her today. And I hadn't even thought that possibly the delay was that the family had been saving up funds so that they could get their daughter some help and support. Another example, just from a few weeks ago, I have a client that I've seen for many months and have been following in the community, and he is fluent in English. He's been here for 5 years and engaged in the education system. And I was helping him to book a COVID vaccination. And so I wanted to be sure that his parents, who haven't yet become fluent in English, would have the information as well. So I wrote down the time and the date and the location, the details of the appointment for the youth, and asked if he'd be willing to pass that information on to his mom. He smiled and said, yeah, absolutely no problem. He'd be happy to do that. A few days later, I bumped into a teacher who was also working with this youth, and she said, wow, like that's really interesting about our youth, eh? And I was like, what's that? And she says, well, he can't read or write in any language. And so, I just realized I missed it. I've been working with him for months, and I hadn't even thought to ask him about literacy or reading. I just made an assumption. And if they hadn't made the appointment, or if they didn't get to get that vaccine, I might have made a judgment or an assumption about whether he really wanted to have a vaccination or not. So I missed what was right in front of me. And we do miss the things that are in front of us. Even, in my role working with newcomers, I'm looking for those things all the time, and I still miss them. And in addition to missing the things that are in front of us, another barrier is that at times there are some situations where we don't know what it is that we are asking patients to do. So let me just give an example. As I work with newcomers, I often have the privilege of hearing their story of their family's migration journey. I met with a mom not too long ago who shared with me her story. She noted that her husband had died in the war, leaving her a single parent with 5 young children. And one day their home was hit by a blast, and the debris of the blast hit one of her sons, and he needed urgent care. With no hospitals in her country, she gathered up her children and journeyed to the border of the neighboring country. She was told she could enter, and her son, who needed the care, but she had to leave. She must leave the other children behind. At that point in her story, she stopped, and with tears pouring down her face, she looked at me and she said, "Can you imagine that?" She ended up leaving her 4 children to get help for her injured son, and just hoping that her children remaining were taken care of by neighbors and friends. And I thought about her question, and I know that I can't, and I don't think that we can imagine what she has faced. And now in Canada, just here recently, as she needs to access ongoing care for her son, she navigates healthcare as a new refugee with little or no English, as a single parent with few or no social supports. And she finds getting out of her apartment difficult, as well as the difficulty navigating transportation. And she's connected to our services. And we ask her to ensure that she arrives to the appointment on time, that she only brings the child who is having the appointment to the clinic. And unknowingly, we ask her in a small way to face the same traumas that continue to haunt her. And if she's late, or if she doesn't show up due to the many barriers she may face, we can easily move into assuming that she doesn't need or want the care, that she doesn't value our time, when really, we just didn't have any concept of what it was that we asked her to do to make that appointment. Nothing about our ask was unreasonable, but I don't think we fully understand the barriers that are in place for many newcomers. So why is the N4 relevant? Because newcomers are in front of us, and because we need to not just have the knowledge, but a perspective that allows us to see more than what is just in front of us. So just as I kind of finish, I want to end with one final story. To me, it's like a metaphor. It's a picture that I keep in my mind as I continue my work with N4 and with newcomers. It's something that just happened a few months ago in the summer. As I mentioned, I care for youth who reside at the Nova Scotia Youth Centre, and I had a newcomer youth who was residing there. His parents, who didn't have really good fluency in English, they really wanted to visit their son. And so they made the trip from the city and set off in their car to get to the Waterville location. After some time of driving, they actually found themselves in Truro, which is pretty well the opposite end of the province of where they needed to be. And they tried to find the right path and the right road. They stopped to ask directions. And after some effort, it seemed that verbal directions or phone or GPS was just not going to be able to get them redirected to the road that they needed to be on. So thoughtfully, a compassionate and kind Nova Scotian, after some time of trying, decided that the best way to get them on the right road was just to get in their car. And so that is what they did. They got in their car and they helped this family navigate until they were on the right road. And I think this story, is a great metaphor, because newcomers aren't asking for a new road or a fast track road or a better road, but health equity means that they are able to get on the same road in accessing healthcare as other Canadians. Healthcare systems are set up as we know them, work well for Canadian-born consumers, but may not be what is needed to help newcomers navigate health in Canada. So we may need to think differently about how to best support newcomers and navigate the road. It might be we have to move beyond the maps, and we might have to move beyond the instructions in the GPS. It might be that we have to get in the car. Thanks.
Thanks, Laura. I love hearing Laura speak and share all of her stories. So my name's Renetta Miro-Lang. I was the Bilingual Services Coordinator at the IWK, and I'm still within the IWK, just in a different capacity. I am now the School Health Partnership Nurse for CSAP, the French School Board. And so when I took N4, it was really relevant to the role that I was doing at the time. And I believe it still is quite relevant because we see a lot of newcomer families within the school health. And so I'd like to share a little bit about one of my favorite courses that touched my work and actually can touch a lot of your work within the IWK. It's a common thread that we have among all of us, and it's a really common thread within the newcomer population. So this course was called Interpersonal Communication. And really, interpersonal skills are the skills that are required to effectively communicate, interact, and work with individuals and with groups as well. So those that are good with interpersonal skills have strong verbal and non-verbal communication skills. And they're often considered people that are good people to communicate with. So to put it simply, interpersonal communication, it's the exchange of information among people. So the information that it can include thoughts, ideas, feelings, and much more. So this communication occurs both verbally with words and non-verbally, encompassing facial expressions, gestures, body language, and tone of voice as well. And so our individual personal communication skills have been developed since we began communicating as children. It's a skill that varies from person to person. Some people are better communicators than others. However, we can take steps to improve our ability to communicate. So looking at 4 different types of interpersonal communication skills, our first one is a listening skill. So it's possibly the most important skill of all the communication skills. And it does include verbal skills as well. So we look at relaxation, a calm, self-confident manner. It allows a more coherent verbal expression, and it also gives the impression of an active listener. A positive attitude. All people prefer communicating with happy, accepting people, showing empathy, understanding the stress in yourself and others. So this allows for self-monitoring of your own personal verbal communication, and it's a greater understanding of the speaker's motivations. So you realize from your tone of voice, maybe the choice of your own words, that's effective in internal feelings and stress, as well as understanding that what you're listening to someone whose speech may be affected by the stress. So it allows you to communicate effectively and accordingly. Then you have assertiveness. This quality, it's essentially and fundamentally a notion that in the participants express of beliefs in ways that others can understand, but also the thoughts and feelings of all who are involved. And then teamwork. So it includes the adaptability and flexibility in dealing with differing personalities and different interpersonal skill levels. Moving on to active listening, it's a successful communication skill. So you're focused on the conversation at hand. You're not trying to multitask, but you're giving the speaker your undivided attention. You don't interrupt a speaker. You interrupting somebody might give them the impression that you don't find what they're saying very important. And then you don't jump to conclusions. Have the patience, you allow people to get to the point in their own time, and you try not to finish the point for them. And then you can ask questions. This shows that you're interested and you'd like clarity about the context. Moving on to the next slide. So 2 other skills to complete it is the written skills that would include the analysis. So a strong analytical and research skills. They're really key and new ideas and getting them accepted. You have computer and literacy skills as well as professionalism. And then with our nonverbal skills, this can say a lot about a conversation. So our body language, our posture, the eye contact. And the eye contact can really be revealing during a conversation. So in some cultures, it may be considered disrespectful or rude. So we really need to know the context and the culture a bit about the person that we're speaking with. And then you have the microfacial expressions. These can say a lot too. Moving on to mindful communication, really it's the starting point for a mindful communication is noticing how communication opens and closes. And so to this, there's a metaphor of 3 lights. So you're seeing the 3 lights now. Like all mindfulness practices, this method is deceptively simple. It really is simple. So the light symbolizes not only the changes in your conversation pattern, but also 3 different state of minds. And so mindfulness is being present in the moment, fully aware without judgment. And so red light, well, when we're intimidated, we're closed off, we're defensive, our red light comes on. Our priorities move on all about ourselves, and we stop using our communication skills to their full potential. And feeling closed off to others, shut down, our ability to communicate effectively. If we're aware of these defense reactions, then we can move on to a yellow light. So moving on into the yellow light, this is a state of limbo. It allows us to move between a green light and a red light. It's in between open and closed communication. We may find ourselves where we're caught by surprise. Maybe it's a surprise of a diagnosis. Maybe it's a surprise intervention that we weren't anticipating. We may feel disappointment. We may be self-conscious or have a loss of trust. This period of transition, it also allows us to decide which way we're going to go, and it can affect a relationship in a positive or in a negative way. You'll decide to shut down and become defensive with a little mindful awareness. You can evoke curiosity and ask yourself why. So this state of awareness can lead to either sharing or withholding acts of kindness and open communication. And then we move on to the green light. A green light is a state of open communication. We're able to trust, we're able to feel empathy and courage, we're relaxed, and we reflect. When we're open, our state of mind is about we and us. The green light allows us to explore our connection with others. It practices acts of kindness, share information, and then we learn from one another. And so we move on, and for mindful communication, the most important thing is to be responsive. Think of the green light, red light game. So the red light, you stop. The green light means you go. Now, unlike the new Netflix series, The Squid Game, no one gets killed because of the green light, red light, but hopefully you'll have better communication strategies. And so I've actually implemented this into my nursing practice now through my N4 course. And now I won't hesitate into stopping a conversation. And I'll let the practitioner know. So say when I was interpreting, I'll let them know that maybe this was enough for today and ask if we could return at a better time. Because when you see that red light come on, the families may not be able to process everything that you're trying to deliver to them. They may have had enough for that day. They may be tired. They may be overwhelmed. So it's good to stop the conversation, save it for a different day if it's possible. I know it's not always possible in healthcare. So moving on, another course that we had was an internship course. And so this internship course was ongoing throughout all of the N4 classes. So it was 6 months each internship. And this was through our online courses as well. So we had both going on at the same time. We had to provide a learning agreement. We had to choose a mentor. I decided to choose my mentor was Tyro, our diversity and inclusion coordinator. Tyro was a great fit for my work and as well for the IWK. We had to provide weekly journals. And then we had monthly group meetings as well. In these monthly group meetings, it was a group meeting of 5 people. We practiced mindful communication. It was a safe space that we could share. We each had to present a case where we could share and really ask our peers across the country to guide us into the situations that we were trying to work through. So it was quite informative. It was a beautiful space to share in. And then we concluded that with a final report. So I'd like to share with you now a case study. And this was my case study that I actually got a chance to share through the internship. I had the privilege of interpreting for a Francophone newcomer family. She's a 30-year-old female refugee from the Congo. Her pregnancy history was gravida 5, para 1, and abortus 3. So quite a significant prenatal history. I met this family at the beginning of her pregnancy. She was referred to us as she was considered high-risk pregnancy to her past miscarriages in her late pregnancy. I was with them for their 12-week ultrasound of gestation, and they concentrated a lot on the cervix at that time because she needed cervicalage in her last pregnancy. And after the last ultrasound, the physician said that her cervix looked good and to return for a 14-week ultrasound. During this second ultrasound, it was clear that there were multiple anomalies with the fetus. So they were offered a few options, either genetic testing through amniocentesis to identify some of the anomalies more specifically, or to abort the pregnancy in early stages of the pregnancy or carry on with it. And they decided to carry on with the pregnancy. I saw them at the clinic every 2 weeks for an ultrasound. So on the third visit, 16 weeks, they were told that their baby had a diaphragmatic hernia. The baby was also presenting with complex congenital heart disease that included several septal defects and valve dysplasia. After the diagnosis, the family was offered several times the option to terminate the pregnancy, as there was very minimal chances of survival. The family had a deep Christian faith, and they chose to pray on the defects and continued on with the pregnancy. So we met in consultation with the pediatric cardiologist, the pediatric surgeon, as well as the neonatologist in preparation for the birth. They all had the same messages. The chance of survival was less than 5%. When you interpret for a family, like I do in my former role, you have a chance to hear what every individual practitioner is saying to the patient. And so this woman was asked about terminating her pregnancy every 2 weeks for the following few months. So this is a closed off family, and I was finding it very hard to read them because they didn't express many emotions. They never shed a tear. And over the few months, I did have a chance to build a relationship with them. It was tiny, tiny baby steps throughout their whole journey because they were quite closed off. And so I was very concerned that they didn't understand the severity of the situation. but also I wanted them to have some hope. I wanted to respect their wishes, their culture, their religion, and their faith. So then I started to ask myself, how do I come up to a point of openness to ensure that this family is clearly aware about their unborn child? And what are the cultural concepts that I and the rest of the staff need to know prior for her to give birth? Are there any specific considerations for the Christian faith? I wanted them to be prepared, but I also wanted to prepare myself to find the words, to find them comfort during the delivery as a nurse. So Tyro, as I mentioned, was my mentor, and she mentored me through this internship. And one of my biggest takeaways from her was not to be afraid to ask them the big questions and to go there, to take a deep dive and ask. So after hearing the same questions every 2 weeks, I stopped the physician and I asked him if I could ask Mom a question to get some clarity. And I asked Mom, why are they not choosing to terminate this pregnancy? And her answer was quite simple. She said, God will choose to take this life if he wants, but I will not. And so from that point on, the nurse in me made sure to advocate for this patient. And then I briefed every healthcare provider prior to them coming in, prior to their interpretation, that this is their wish and their faith, and not to ask the question again. Mom delivered a beautiful baby, full-term baby girl. She took a loud first cry. She took a few breaths, and then she died peacefully in Dad's arms. The family prayed, and then Dad put on some loud cultural and chanting hymns. It was a very powerful and cultural experience. And it's definitely one I will never forget. It was a privilege to be part of their journey through my work and this internship. And by the end, this family opened up to me in so many ways about sharing about their culture, their beliefs. We planned the next day I returned, and I was able to help them plan funeral arrangements. And it was a beautiful friendship that we developed. So I was grateful to apply some of my N4 learnings with this family and to provide them with a culturally accepting and safe space for their traumatic life experience. And I'm happy to report that she's actually expecting another healthy baby this time. So moving on, at the IWK, we do have some free tools that you can use and that you can provide effective communication. And so something that is bringing me back to my former position is actually interpretation. It's something that with newcomers we have, and that is accessible, it is free, and it's important to let your families know, bringing back to Laura's story. So it's something that's available 24/7 via telephone, via iPad, or face-to-face. So I know that the iPad's only available through our emergency department right now. And in case you're wondering what iPad is, iPad interpretation, it's called an Insight app. It's a face-to-face within 30 seconds with an interpreter. So these are used throughout Canada right now and throughout the US to access interpretation very quickly, especially in emergency departments. So we're working to expand that, the iPad interpretation at the IWK, and the discussions and decisions are being held around, and they're happening at the VP and director level currently. We have about 10 available. They're limited at this time. And so they'll be prioritized with the patients and the clinical needs areas in various areas throughout the IWK. So some tips that I have for you to share this morning about how to use interpreters. There's 10 of them. There's 10 tips. So first of all, seek out a professional interpreter. That is very important. Do not use a family member. I can't stress this enough. It is part of our policy not to use a family member. A family member can be very, can have a different opinion, can have a distorted message, maybe does not understand the language as fluently as you would expect him to. So do not use a family member. Just seek out a professional family member. Next slide, Chantal. And then position yourself in a triangular way so that everybody can see each other. So sometimes you'll see an interpreter move around. That's because she wants to see the person who's speaking as well as the patient himself. Also limit the noise to the room. That's very important because when it's loud, an interpreter will have a harder time to be able to speak. Yes, and that's a great point. I see somebody saying a question about, identifying the gender. In some cultures, they do prefer a female or a male interpreter, depending. So you can always ask about the gender of the interpreter. Number 3, hold a brief meeting with the interpreter. That's something that I found I learned quickly as an interpreter. You don't want to be blindsided. You want to have your words prepared. And so especially if you are announcing some news, a new diagnosis, you want the interpreter to be equipped and to be able to deliver this information to the person. Moving on to number 4, you're going to make eye contact with the patient. You're speaking directly to the patient. So make eye contact with the patient, not the interpreter. So you're not speaking with the interpreter. And a lot of times I do catch physicians or nurses talking directly with me. I'm not the patient. So make sure you're speaking to your patient. Moving on to tip number 5, read the body language. Look for signs of comprehension or confusion. It's not up to the interpreter to make sure that the person has understood. You are responsible to make sure they understood. Tip number 6, speak in loud, in a normal voice, not too fast, not too loud. Pace yourself, allowed for the time to take turns in speaking, and not too loud. Even if you're screaming, they still can't understand what you're saying. It's a different language. So speaking louder will not help the situation at all. Tip number 7, ensure that you have cultural sensitivity. If you're not understanding why your patient is doing the things he's doing, or the family, you're having a hard time navigating through them, it's okay to ask your interpreter about some of their beliefs and some of their cultural traditions to get a better understanding about it. Number 8, you want to avoid medical jargons and technical terms. So you want to make sure that you're meeting the people where they are. You want to make sure that it's simple terms and it's in English, just like you would speak to any normal, regular English family. Do that while you're using an interpreter. Tip number 9, allow enough time for the interpreted session. It takes about double the amount of time, unfortunately, but is really well invested. And so you may clarify some things with the families, and it'll save you time in the long run. So allow yourself enough time for the interpreted session. And tip number 10, never leave the interpreter alone with the client. So this is something I can't stress enough. The interpreters are not there to support the family. My role was different as a nurse interpreter, but the professional interpreters that come into the IWK, they're not there to provide support, to hold the baby, to provide support to the family. They're not there as a friend. They're there as a professional body and treat them as such. So invite them to sit at a different spot. When they go into the room, they come into the room with you, but when you leave the room, you bring them along with you. And when you're using an interpreter, one of the best practices that I can't stress enough is documentation. Make sure you're documenting that for legal issues that an interpreter was present throughout your consultation. So to leave you and to wrap this presentation up, we want to leave you with some resources. One of the best resources from N4 is this fantastic website. It's called the National Newcomer Navigation Network. You can Google it, N4. It's a website that provides education, virtual, go back, Chantal. Thank you. Virtual discussions, networking, the sharing of data and information and resources. So it does have a lot of, it has an online program, e-learning, conferences, discussion boards. It's a great forum. If you want to ask a question, I did ask a question regarding labor and delivery on the discussion forum, and I had answers from across Canada of what they were doing with their newcomers for birth registration. So it's a great sharing platform. Now you can move on, Chantal. And so to become a member of this, to access it, you need to become a member. It's easy and it's free. It doesn't entail anything. But I would have to say that some of their webinars, and they do include webinars, some of them are, so they're live, but they're taped just like this Grand Rounds, and they're accessible at any time. Some of the conversations that I've seen or some of the webinars have been compassion fatigue, vicarious trauma and burnout, immigration and refugee services for LGBTQ2S, bridging the gap between newcomers and Indigenous people, the impact of COVID-19 on maternal health in newcomers. So there's a variety of different webinars that are quite relevant to these times, to nowadays. And so with that, I leave you with this beautiful painting. It was actually these are pictures that we're taking from an article from The Guardian, and they're a reflection from a refugee, and the refugee's art is to imagine a better world in pictures. And with that, I thank you for listening, and I hope you learned a little bit more about N4. And I open the floor up to any questions that you may have.
Thank you, Renette, and thank you, Laura and Chantal. That was a very great overview and lots of wisdom in there too for all of us. We are expecting more refugees from Afghanistan. We certainly had a large cohort a few years back from Syria. And unfortunately, one of the things that we've heard about is that our newcomer clinic, because of resource issues, are not able to accept any new referrals as of a few weeks ago. So that's put everything a bit at risk. Hopefully, I know the provincial government are aware of it. Hopefully they're going to be able to work that out. That may have people coming to our merge more often or with bringing kids. So that could have a spillover effect for us as well. So we're going to have to work with our government partners on that issue. I'm glad you highlighted the Caring for Kids New to Canada website from the CPS, but obviously that's just one part. And as you've all explained, there's a lot more in terms of our mindsets and our ways that we listen and try to understand, and being humble and realizing there's things we may not know in terms of some of our own cultural competencies. I just wonder, I'll ask any of the three of you, the tips for using interpreters when we're here in the hospital, either in the clinics or on the wards. Are those tips summarized, or is there sort of an FAQ sheet on Pulse that we could refer our learners to or ourselves to if we want to just refresh ourselves and how best to do that? I've seen this presentation once or twice before, and I certainly learned a lot, but it'd be nice to have somewhere to go to just to refresh if we're coming up with especially a challenging interpretation, a challenging clinical encounter where we need interpreters.
Yeah, no, that's a great point, Andrew. Actually, so this is a presentation that I've shared, those tips I've shared throughout, but it's definitely something that I can add to the Pulse website. On the Pulse site under language services, it's an updated site. You can find everything around translation and interpretation. So I can add those tips there so that people can refer to them over there. And somebody did ask in the chat discussion, is tip number 7, that's the discussion between the family or after the meeting, and that was about cultural beliefs. So you can actually judge how it's going with the family, and if you're not going anywhere with the family, I would ask it outside of the room, either before or after entering, just to get some clarity from the interpreter because they may have some insight about what's going on, or because of their cultural beliefs.
All right, great. And I'm just looking to see if in the chat room various people are replying to the N4 resource link, and that was provided too for everybody. It's in the chat box, folks. And all right, any other questions, people? I think everybody's been suitably impressed by your presentation, folks. And this is probably something we should do every year or two, just as an update, because it's an ongoing, evolving issue. And I think for us in Nova Scotia, well, we've had immigrants for sometimes, it's not perhaps like some of the big Canadian central cities where this is an everyday thing. I think we're going to see more people coming to Nova Scotia as the larger Canadian metropolises like Toronto and Vancouver and Montreal. It's just becoming unaffordable for people to even live there. Even in Nova Scotia, housing, as we know, is an issue, but it may be even still more affordable. And I know the Premier had mentioned in his election speech that they're hoping to double the population in Nova Scotia in the next 20 or 30 years. That's going to mean a lot of new Canadians coming in. So we have to definitely get good at this. I'm just going to check that chat box one more time.
I can see that Dr. Norley McDonald has her hands up.
Oh, I'm sorry, Noni, I didn't see your hand up. Go ahead, Noni, please.
Hi, all of you. I think you've done a most excellent job. Full disclosure here, I was one of the people who started caring for kids new to Canada decades ago and was in Ottawa at that time at the Children's. And this was a huge problem for us because we had a big influx of Somali refugees. And I just wanted to give two quick stories to really emphasize how we miscommunicate when we don't really understand cultural differences. So in the TB clinic, we had a 9-year-old boy who had really bad TB and was very, very ill. And we had sent him home on his medications. And a month later, he came for follow-up. And there were two physicians who worked in the clinic, myself and Victor Marchessault. And Victor Marchessault happened to see him the second time. And he came to me, because I was seeing another one, and he said, Noni, he said, you saw this little boy last time. Do you think it's possible he could have gained 15 pounds in a month? And I said, well, no. I said, this boy was really, really sick. And I was hoping he was going to be holding his own on his medications and not getting sicker. And to make a long story short, when I went in to see the father with Dr. Marchessault, when we quietly sat down and said, because the name was right, the date of birth was right, that we just checked, we had the right patient and everything. Well, when this boy came, the father had died in Somalia, and the brother, of course, would take any children that were from the father that had died, because that's culturally what would happen. So this was his son, even though it wasn't his birth son, okay? But that's different culturally. And then the other point was he was afraid to bring the other boy back, because although he was a bit better, he wasn't a whole lot better, and he was afraid he wasn't going to get any more free medications unless there'd been a big improvement. So like 15 lessons in this story that were huge for all of us. And it was not a language problem. It was a cultural misunderstanding problem. He didn't know how our system worked. We didn't understand how their family system worked. And when we got that all sorted out, we became best friends for the next year while the little boy, and the father did go home and bring the other son in, you know, now that he knew it was all right. And then we had in the same group, we had another mother who had a child who was 18 months old, who had, his left lung was just all TB, and it needed to come out if he was going to survive. And mom said no, and father said no, because it would be God's will whether he survived or not. And we just quietly said, maybe God's will was bringing you to Canada to have a chance for your child to survive. You go home and think about it. And they came back the next day and agreed to the surgery. So I think you also have to work with the culture, not just necessarily accept it. I think the case you gave, no, that was a completely different thing, but don't always, if they say it's God's will, you need to help understand what they mean by that. So over.
Thank you, Noni, for those wise insights. And I'll just refer Renette, Laura, and Chantal just to Charlotte Rioni's chat message. Wondering, we have lots of pamphlets that we give out to parents when they have to have things in the ED, and interpreters will go over it with the parents. But what about having some of these pamphlets translated version online so they can refer to them at home in case they forget anything? That's a very interesting suggestion. Anybody want to tackle that one?
Well, I actually know that one of the great websites and resources, and some of the clinics use them actively, is actually the Sick Kids website, because they're available in multiple languages. So we're fortunate that their practices are pretty equal with the IWK ones. And sometimes the pamphlets kind of look alike, fortunately. And so I know that a lot of different clinics throughout the IWK have printed off those resources from the Sick Kids website.
Thank you. And Renette or Laura or Chantal, you know, during your discussion, you had mentioned about having a meeting with the interpreter before you go in with the family, just to introduce yourselves and give the interpreter a heads up. When it comes to, so it's one thing, the language translation, as you pointed out, but you've also taught us about, you know, the cultural understandings and the competencies that we may well not have. And not all the interpreters may speak Arabic, but not come from, these people may come from a different Arabic speaking country, but for example, but is there an opportunity, or can you give us a little advice on the interpreter who might have quite a bit of insight into those cultural competencies? What would we ask them before going into the meeting? How can we use the interpreters for that part too, so we're not going in completely blind when we're asking questions and approaching situations?
I mean, I can just share kind of what I've done. If there's kind of a cultural question that I might have for the family, it's really just an open conversation with the interpreter to say, you know, would you be from the same cultural group? And what is your understanding? And if they aren't from that group, then, you know, what would be, you know, how would you consider maybe I could ask this question that would be respectful of the culture and curious? And then another I guess another consideration with the interpreter as well, especially when you're hearing often because it's mental health or I'm asking about the migration journey, you're also hearing quite a lot of really heavy information. And especially if the interpreter has had a similar journey or have experienced similar trauma, you can also kind of recognize that sometimes it impacts the interpreter as well. So I think in addition to us being mindful of the patient and that interaction and gathering the information we want from that, you know, that assessment or that interaction is also to be mindful of, you know, the interpreter as our colleague, just being able to kind of, you know, check in and ask those questions. So I, you know, for me, it's just that openness to be curious and ask and say, you know, I hopefully I'm asking this in the right way. That's a very respectful way. But what would be your advice? And do you have insights culturally as to what their answer meant or how I could approach this question further?
Thank you, Laura. Well, I'm looking at the time, folks. I think we can wrap it up. And someone has, there's one other thing, and Catherine, we've created car seat safety resources in 9 most common languages in the region. We created video resources for interpretation. Okay.
Yeah, she beat me to it, Andrew. To second Renette's point, I wanted to chime in and just indicate that Child Safety Link really works strongly to inquire about the languages that are most requested and really to make a lot of our resources that we focus on in the areas of injury prevention accessible for different languages. And so Catherine has worked very hard on creating those in those 9 different languages with interpreters to ensure that the important pieces of car seat safety are being communicated effectively.
Okay. Well, thank you, Renette, Laura, and Chantal. Again, a fantastic talk. I've learned a lot today. And folks, just so you know, this session is recorded. It's on the Department of Pediatrics YouTube site. If you can get a hold of Denise Doucette, who's my admin, if you want to know how to access that. And you can share it with your learners and your colleagues if they weren't able to see this today. So once again, Renette, Laura, and Chantal, thank you very much. And have a nice day, everybody.
Thank you.
Thank you.
Chantal and Laura, do you want to stay on for a minute? I'll call you Chantal.